I'm going to talk about the phase 1 of the knee osteoarthritis use of decision aids and shared decision making at Dartmouth Hitchcock Medical Center. And then Melanie will take over and talk about phase 2. And then she and Carol will have a little bit of a conversation, because the three of us actually were on the design team that spent a year doing the redesign that transitioned us from how we did it in phase 1 to how we're currently doing it, with which was forced in a way by the change to a new electronic medical record. So really not designed based on what the humans wanted, but really what the technology would allow us to do in some senses. And then of course we had to redesign it to make it work better for us. So phase 1, which is 2005 to 2010, we started with a workflow map. So I sat down with an orthopedic surgeon newly arrived at the Dartmouth Hitchcock Medical Center. And for those of you who don't know, our medical center is it's basically one big building, and all the doctors work there, and all of the internal medicine and specialty clinics are housed in one physical space. And a few of the family practices are in the community, but it's all right here in Lebanon. And we have a center for shared decision making, which is a reception desk, like a video store, where we keep our decision aids. So we centrally control the distribution of decision aids at our medical center, which is just, you have to understand that that's how we do it there to have all of this make sense. So I sat down with an orthopedic surgeon who basically, he was open to it. He's a young guy. He's new to the faculty, but he'd been told that he was going to be integrating the use of decision aids into the process of care for knee and hip osteoarthritis. So he came up with this first design, and it doesn't really matter so much what it says in there, but it's basically, we identify the patients, we tell them what their options are, the surgeon makes a recommendation, and then down there at the bottom, and the patient goes, either says, yes, I'll do the surgery, or no, I won't. And then I said, okay, we have to think about every step, like how do these patients come into your system, who schedules them, which doctors are going to be using the decision aids, is everybody going to do it, or is it just going to be a couple of you? So how are we going to make that work? And then he came back, he had gone to the scheduling secretaries, and he came back with this algorithm that they were using. So they sat by the phone with this triage sheet, and if a patient fell into one of those 9 boxes, they were put with the right doctor for the box that applied to them. So not every doctor sees every type of knee pain, and not every type of knee pain was going to be amenable to what we were trying to do. So just to get a sense of that, there were a number of providers. Not all of them were participating. There are a whole bunch of different reasons why you have knee pain, and there was no way electronically or efficiently to identify who those people were ahead of time. So this is what we had to start with, and your work will be to do some workflow mapping. So as you think about where do you start, this is where you start, is at the level of exactly what happens when that patient comes into your system. Where do they come from? Who do we send them to once we hear about them, and how do you make sure they get a decision aid at the right time in all of that? And then we also did some of the mapping that was sort of surgery-centric, so to follow through what exactly happens with a patient who does have surgery, and all the steps that happen preoperatively and getting the consent signed, and then during their operative phase and postoperatively, because we really wanted to map out every step of the patient experience and then figure out where we could intervene with decision support. And so then we revised our original map, as you can see, and the one thing we added was shared decision-making aid. We'll give it to them here. But as you can see, this doesn't tell you, are you going to mail it to them? Are they going to go pick it up at the center? Who's going to remember to give it to them? Which staff person is paying attention to the fact that they are actually eligible and that they are amenable to this? So this was how we began to do decision support for folks with knee osteoarthritis. Then 2 years after the first map, as you can see, we've really evolved. We got a better map-making piece of software. and so we had, the pictures were way prettier. Plus, I was making them. The orthopedic surgeon wasn't making them anymore, so, we could fool around with this. But it looks pretty, but in fact, it's a really good way to conceptualize what you're doing with patients and look at where the steps are and where you might intervene. So the issues of timing that we've heard everybody talking about, this is a really good way to kind of get a have everybody on the team who's doing this design have a sense of who does what, because a lot of times the surgeon doesn't know necessarily what the scheduling secretary or the OR scheduler is doing, or he only knows about the ones that work with him directly, and each of them do it a little differently. So the mapping can get very detailed, and you have to remember to think of every player in this interdisciplinary team that you've got here. And so part of this is how we wanted to intervene and all the questions we were asking patients and at what time. But then some of it is always, and this is what we would like to do in the future. So at some point what we're hoping is not only to ask these questions, to give them the decision aid, to document the conversation, but also to feed back to the clinicians the information that we're getting. So that was kind of the wish list there. So what happened was we give out decision aids, and this is a post-visit model. The patient goes to the doctor, yes, you've got knee osteoarthritis, yes, you're a candidate for surgery. I would like you to go pick up this decision aid, so you need to hobble on down to the Center for Shared Decision Making, which is not too far down the hall, and pick up a decision aid. And at that point, we would give them, because we were doing research for the Foundation for Informed Medical Decision Making, we'd give them the video and a paper questionnaire, which asked them some pre-video, post-video questions about what they were leaning towards, and then it tested their knowledge. It asked them about their values, and then we stored that data in our beautiful database. And it wasn't useful to anybody in real time. But we do have an extremely excellent data analyst who puts together beautiful reports and looks at decision quality and which values are driving people towards the surgery decision versus the non-surgical decision. And these reports are really great. And sometimes we actually remembered to send them to the surgeon so they could see what was happening with their patient population in aggregate, every 3 months or once a year. I love these reports, but I'm sorry to say that they're very clinically useful, but not when you can't give them to the clinician in real time. So we've always been frustrated by that. But I just wanted to say that I think we've evolved enormously with this reporting, and this is the most recent version. So this is the dashboard that can be used for reporting to our orthopedic surgeons, and it shows a lot of data about volumes of decision aids, but also about patient decision making and by clinician who has ordered how many. So, as Carmen said, and other people have been saying all day, when you compare yourself to your other clinicians or other people in your practice, or the nurses or whoever's doing the prescribing, it kind of gets people to say, oh yeah, I would like to be up there. So these reports actually are effective because our doctors really are interested in what their patients are saying and how they compare to the other folks in their section. And this is something that I believe, and Stephen, you could speak to this, but that will be more routinely fed to our clinicians. But I think we've also, and Melanie is about to tell you about this, what we've also done with the new EPIC system is found a way to deliver patient-specific information to the clinicians in real time, although it's much more limited than what you see here. So the system for 5 years has been patient comes to pick up a decision aid after a clinician remembers to refer them for it. They take it home, they watch it, they fill out the paperwork and send it back to us, and then they revisit the decision with the surgeon. And often it's a matter of you go home and watch this, and if you think you want to see me again, give me a call, send me an email. Fortunately, it's usually not a very urgent situation, and there's a kind of a system they have in place for sort of closing the decision-making loop in this model. So a year and a half ago, maybe, a team was convened because a new electronic medical record was going to come in and replace our homegrown version. And knee osteoarthritis was chosen as the kind of the prototype for mapping the process of care. So a group was convened that met for a year, and all three of us were on that group. Carol and Melanie every week and really running the show, and I would step in when they had a need for a shared decision making issues to be resolved, and so I was kind of in and out. So these guys did this extraordinary work that Melanie and Carol are now going to talk to you about, and really sort of emphasize the issue of the fact that switching to a new electronic medical record was driving how we were going to do our work and also keep our shared decision making or not.